Welcome to this channel, where we delve into pharmacology to build a solid foundation for healthcare professionals and pharmacy professionals. In our last video, we explored the introduction to pharmacology, covering fundamental concepts of pharmacology such as the importance of drug actions, and how these interactions form the basis of clinical treatment. Today, we'll deepen our understanding as we discuss pharmacodynamics, a cornerstone in pharmacology that examines how drugs work at the molecular and cellular levels. Pharmacodynamics is vital for healthcare professionals because it reveals how medications interact with receptors, their effectiveness, and safety. Understanding pharmacodynamics helps clinicians determine dosing, anticipate side effects, and optimize patient care. The World Health Organization highlights that nearly 50% of all medicines prescribed are either not taken correctly or have suboptimal dosing, leading to therapeutic failures and adverse effects. Therefore, mastering pharmacodynamics is critical for effective and safe drug therapy in pharmacy and clinical practice. By the end of this video, you'll understand key drug receptor interactions, that is how drugs target specific receptors and initiate cellular effects. Dose-response relationships, which is the quantitative analysis of drug concentration and biological response. Therapeutic index and therapeutic window, which is important in defining therapeutic safety for optimal dosing. Types of agonists and antagonists, focusing on their mechanisms, clinical examples, and importance in drug selection. Signaling pathways and receptor dynamics, focusing on how receptors like GPCRs and ion channels transmit signals. Receptor regulation and adaptation, looking at concepts such as tolerance, desensitization, and clinical implications. Drug-receptor interactions and effector mechanisms. Drug-receptor interactions are crucial for determining both the specificity and magnitude of a drug's action. Receptors are proteins that bind specific ligands, allowing drugs to exert targeted effects. Agonists bind to and activate these receptors, initiating a response, while antagonists block this activity by preventing receptor activation. Once a drug binds to its receptor, effector mechanisms convert this interaction into cellular responses that drive therapeutic effects. The overall efficacy of a drug is influenced by its binding affinity to receptors and its intrinsic activity, which together dictate the strength and type of response. Receptors have unique binding sites that only recognize specific ligands, leading to highly selective effects. For example, beta-adrenoceptors in the heart respond to adrenaline by increasing heart rate and contractility. After binding, a conformational change occurs in the receptor, activating effector mechanisms within the cell. Some receptors, like ligand-gated ion channels, directly control ion movement across membranes, such as nicotinic acetylcholine receptors. Others, like G-protein-coupled receptors, GPCRs, generate second messengers such as cyclic AMP, CAMP, to propagate the effect as shown in this diagram below. We want to briefly look at dose-response relationships. So, what is a dose-response relationship? A dose-response relationship describes how the intensity of a drug's effect changes with varying doses, revealing the drug's potency, efficacy, and threshold levels required to elicit a specific biological response. This relationship aids in determining optimal dosing for therapeutic effect. Graded dose-response curves. A graded dose-response curve illustrates the relationship between the response of a specific receptor effector system and increasing concentrations or doses of a drug. As the concentration of the drug rises, the response of the receptor effector system is plotted, enabling analysis of how effectively the drug activates the receptor and produces a physiological response. Two important parameters can be obtained from a graded dose-response curve, that is the Emax, which represents efficacy of a drug, and EC50, which represents potency of a drug. Emax represents the maximum achievable effect of a drug when all receptors are fully activated. It indicates the drug's maximal efficacy, beyond which increasing the dose does not enhance the therapeutic response. A little later in the video, I will delve deeper into the concepts of efficacy and potency, providing a thorough explanation of their significance and how they influence drug action and therapeutic outcomes. So, for instance, morphine has high efficacy as an analgesic, and it is ideal for severe pain relief. On the other hand, EC50 is the concentration at which a drug achieves 50% of its maximum effect. For example, drugs like fentanyl are more potent than codeine, meaning lower doses achieve similar analgesic effects. Quantile dose-response curve. A quantile dose-response curve represents the relationship between drug dose and the percentage of a population showing a specified effect, e.g., therapeutic or toxic response. It helps determine parameters like ED50, TD50, and LD50, reflecting the dose required for effects in 50% of subjects. ED50 represents the dose at which 50% of a population achieves the intended therapeutic effect in a quantile dose-response relationship. It indicates drug potency and is key for comparing the efficacy of different treatments. TD50. TD50 represents the dose at which 50% of a population experiences a toxic effect, based on a quantile, all-or-nothing, response. It helps determine a drug's safety margin and toxicity profile in clinical use. LD50. LD50 lethal dose 50 represents the dose of a drug required to cause death in 50% of a test population, and it's a metric that is also obtained from a quantile dose-response curve, indicating the drug's acute toxicity level. To further elaborate on the concepts of efficacy and potency. Efficacy and potency are key pharmacological concepts that describe a drug's therapeutic effects. Efficacy refers to the maximum effect a drug can produce, regardless of dose. For example, morphine has high efficacy as an analgesic, providing substantial pain relief. Potency, however, reflects the drug dose required to produce a given effect. A more potent drug requires a lower dose to achieve the same effect as a less potent one. For instance, fentanyl is more potent than morphine, achieving comparable pain relief at a much lower dose. While potency concerns dose, efficacy focuses on the achievable therapeutic outcome. Before we move on to discussion on types of ligands, let me explain here what therapeutic index is as well as therapeutic window. The therapeutic index, TI, measures a drug's safety margin by comparing its toxic and effective doses. It's calculated as TD50 divided by ED50. As defined before, TD50 is the dose causing toxicity in 50% of subjects, whilst ED50 is the dose effective in 50%. Warfarin has a low therapeutic index, around 2 to 3, meaning the toxic dose is close to the effective dose. It requires frequent INR monitoring to avoid bleeding risks. In contrast, ibuprofen has a relatively high therapeutic index of about 50, allowing safer dosing without intensive monitoring, as the risk of toxicity at therapeutic doses is low. The therapeutic window, TW, is the dosage range between the minimum effective concentration, MEC, and the minimum toxic concentration, MTC, ensuring therapeutic efficacy without toxicity. For example, digoxin has a narrow therapeutic window, requiring careful monitoring, whereas amoxicillin has a wide therapeutic index, offering greater safety at varying doses. We want to look at types of ligands, and in this case are drugs. There are four main types of ligands, which are agonists, full agonists, partial agonists, inverse agonists, and antagonists. We will look at each type and the subtypes that fall under it. We will start with agonists. Agonists or full agonists are drugs that bind to receptors and fully activate them to produce a maximal biological response. An example is fentanyl, a potent full agonist of opioid receptors, often used in pain management. In contrast, partial agonists like buprenorphine at opioid receptors elicit only partial effects, making it ideal in pain management with a lower risk of respiratory depression. Buprenorphine is also opioid dependence treatment due to its partial agonist effect, reducing withdrawal symptoms and cravings with a lower risk of misuse and respiratory depression. Inverse agonists are drugs that bind to the same receptor as agonists but produce the opposite effect, reducing the receptor's baseline activity. You might be wondering, what is the difference between an inverse agonist and an antagonist? An inverse agonist reduces a receptor's baseline or constitutive activity, while an antagonist only blocks the receptor from being activated by agonists without altering its intrinsic activity level. An example of an inverse agonist is ranitidine. Ranitidine acts as an inverse agonist at the histamine H2 receptor, lowering gastric acid secretion by inhibiting constitutive receptor activity, which is beneficial in treating conditions like peptic ulcers and gastroesophageal reflux disease, GERD. Let's now look at antagonists. An antagonist is a substance that binds to a receptor without activating it, blocking or reducing the effect of an agonist or natural ligand, thereby inhibiting a physiological response. We have about 4 types of antagonists, which are competitive antagonists, irreversible antagonists sometimes referred to as non-competitive antagonists, then physiologic antagonists and chemical antagonists. A competitive antagonist binds reversibly to the same receptor site as an agonist, blocking the agonist's action without activating the receptor itself. This inhibition can be overcome by increasing agonist concentration. For example, propranolol is a competitive antagonist of beta-adrenergic receptors, blocking effects like increased heart rate by competing with endogenous catecholamines. A non-competitive, irreversible antagonist in pharmacodynamics binds permanently to a receptor, altering its structure and preventing agonists from activating it. This decreases the maximal response achievable, regardless of agonist concentration. For instance, phenoxybenzamine irreversibly binds to alpha-adrenergic receptors, reducing blood vessel constriction despite increased levels of noradrenaline. So unlike a competitive antagonist, the effect of which can be overcome by increasing agonist concentration, a irreversible antagonist inhibition cannot be overcome by increasing agonist concentration. The third type of antagonist is called a physiologic antagonist. A physiologic antagonist is a substance that counteracts the effects of another by working through a different physiological pathway, rather than directly interacting with the same receptor. For example, insulin and glucagon act as physiologic antagonists. Insulin lowers blood glucose levels, while glucagon raises them, balancing blood sugar via separate mechanisms. A chemical antagonist binds directly to and neutralizes a drug or endogenous compound, preventing its action without involving receptor interaction. An example is protamine, which binds to and inactivates heparin, counteracting its anticoagulant effect and restoring normal clotting function. Let's now discuss signaling mechanisms. Let's start by defining what are signaling mechanisms. Signaling mechanisms refer to the processes through which drug-receptor interactions trigger a cascade of biochemical events within a cell, resulting in a specific physiological response. Receptors utilize varied signaling mechanisms to produce effects. Drugs, which in this case act as ligands, bind to at least 5 types of receptors' effector systems to exert their effects. First, some drugs diffuse across membranes to bind intracellularly, such as steroid hormones. Second, transmembrane enzyme receptors, like insulin receptors, have external receptor and internal enzymatic functions. Third, ligand-activated receptors link to cytoplasmic tyrosine kinases, e.g., JAK-STAT pathway activated by cytokines, that control transcription. Fourth, transmembrane ion channels are regulated by drug binding, exemplified by benzodiazepines affecting GABA channels. Lastly, G-protein-coupled receptors, GPCRs, such as beta-adrenergic receptors, activate separate molecules through a coupling protein, leading to varied cellular responses. Receptor regulation in pharmacodynamics refers to how receptor availability or responsiveness adjusts in response to prolonged drug exposure, maintaining cellular homeostasis. Receptor adaptation, or desensitization, is a process where receptor responsiveness to a drug decreases over time despite constant exposure. This can result from receptor phosphorylation, internalization, or degradation. For example, beta-adrenergic receptors undergo desensitization with prolonged agonist exposure, such as with albuterol in asthma management. Upregulation. Receptor upregulation refers to an increase in receptor density on cell surfaces, often in response to chronic antagonist exposure, enhancing cellular sensitivity. For instance, prolonged beta-blocker, e.g., propranolol, use can upregulate beta-adrenergic receptors, heightening responsiveness when the drug is withdrawn. Downregulation involves receptor reduction from sustained agonist exposure, reducing cellular responsiveness, for instance the downregulation of opioid-MOR receptors when there is prolonged exposure to an agonist like morphine. Tachyphylaxis is a rapid decrease in response to a drug after initial administration, due to receptor desensitization or depletion of mediators. It commonly involves G-protein-coupled receptors, as seen with beta-2-adrenergic agonists like salbutamol, where repeated doses lead to reduced bronchodilatory efficacy due to receptor downregulation. Now that we've explored the key concepts in pharmacodynamics, let's take a moment to recap what we've covered. First, we discussed drug-receptor interactions, where we learned how these interactions initiate therapeutic responses and are fundamental to understanding how drugs work. Next, we moved on to dose-response relationships, highlighting how they guide our understanding of a drug's efficacy and potency, allowing us to predict the effects of different doses. Then, we looked at the therapeutic index and therapeutic window, which established the safety ranges for drugs, helping us to minimize adverse effects while maximizing therapeutic benefits. Next, we examined agonists and antagonists, emphasizing how these molecules modulate receptor activity and influence our clinical choices in treatment. We also explored signaling pathways, which determine how drugs transmit their effects at the cellular level, illustrating the complexity of drug action within the body. Finally, we discussed receptor regulation, which governs tolerance and influences responses to long-term therapy, highlighting the dynamic nature of drug interactions over time. In our next video, we'll tackle pharmacokinetics, the journey of drugs through the body. I encourage you to check out that video. For those interested in further learning, consider resources such as Katzung and Trevor's Basic and Clinical Pharmacology, Rang and Dale's Pharmacology, or British National Formulary, BNF. Conclusion. As we wrap up this topic of pharmacodynamics, I hope you gained valuable insights into how drugs interact with receptors, the importance of dose-response relationships, and the intricate signaling pathways that drive therapeutic effects. Understanding these concepts is essential for anyone working in the field of pharmacology or healthcare, as it empowers you to make informed decisions about drug therapy. If you found this video helpful, please give it a thumbs up and consider subscribing to stay updated on future content. Don't forget to share your thoughts or questions in the comments below, I'd love to hear from you. Remember, the journey of learning never ends, and I'm here to help guide you along the way. Thank you for watching, and I look forward to seeing you in the next video.